Okay, we're back with the next set, working backwards. I'm going to talk about pulmonary vascular disease next. When we talk about pulmonary vascular disease, we've talked about a little bit this before, but one of the biggest issue with pulmonary vascular is the pulmonary embolus. Your book says about 650,000 cases a year, and with pulmonary embolus, those are pretty deadly. About 8 to 10% of people die within 1 hour of having a pulmonary embolus because of respiratory failure. Um, so the issue there is mostly these are DVTs that a clot broke off, became a thromboembolus, and occludes the vascular bed, causing a lung infarction. Um, Important to talk about Virchow's triad. Virchow's triad is a way of classifying predisposing factors to a pulmonary embolus. And Virchow's triad, and you do need to know this, this is a test question, uh, categorized by the triads categorized by three things: venous stasis, a hypercoagulable state, and an injury to the endothelium, which, as you know, triggers coagulation. Your book does a really nice job of talking about some of these factors, but the venous stasis, so a post-operative condition is going to can cause a sluggish vascular system. Certainly, we've talked about immobility and air travel. You've probably heard that getting up and stretching your legs on a long air flight is helpful at decreasing the risk of a pulmonary embolus because of being a pressurized cabin and having and not moving. That increases the sluggishness. Certainly obesity, because there's a lack of flow through the veins. And then keep in mind that a heart issue like a dysrhythmia, where the heart is not, it's kind of quivering, but it's not effectively creating a nice strong pump, and therefore not moving that blood, and the venous side gets sluggish. We talked about this in the early portion of the cardiovascular system, if you want to look and refer back to your notes. And then the other thing, the other heart issue is congestive heart failure. If the heart is having a difficult time moving the blood, then certainly you're going to get the venous congestion. Regarding hypercoagulability, oral contraceptives, long known, especially oral contraceptives in combination with smoking, though smoking itself will increase the coagulable state. Oral contraceptives or in combination with smoking and smoking itself. Pregnancy, because that puts pressure on the right side and causes on the portal system. Polycythemia, because of increase in the number of red blood cells, increases the coagulability, makes them sticky. Any kind of clotting disease like mutations, and those are usually congenital effects of those mutations. So those clotting diseases, hemophilia, etc., or the opposite of actually hemophilia, which would trigger clotting. And then antibodies like antiphospholipid antibodies, which would occur in SLE or any immune disease related to SLE that would cause cause antibodies, antibody destruction, and that would predispose to increasing coagulability. And then endothelial injury, Most often this is secondary to a trauma. Can be due to a sepsis, especially some of those gram-negative bacteria. Burns would certainly contribute to this, and then surgical procedures, which could cause damage to the endothelium, would all contribute to the Virchow triad, keeping in mind that none of those things in isolation would necessarily trigger this, and all could, but the combination of those three factors would lead to this. Symptoms of a pulmonary embolus, certainly dyspnea, always answer dyspnea. About almost always, 80 to 90% of people would experience shortness of breath, and then certainly a tachypnea, so an increase in the respiratory rate. There can be agitation and anxiousness if in a smaller embolism. That could be an early symptom, but certainly then we would see tachycardia, increased heart rate, and then pain with inspiration because of the infarction. And then that certainly could quickly, as I mentioned, even within an hour, quickly progress to a right-sided heart failure, shock, and respiratory failure. Continuing right on into pulmonary hypertension, which is quite closely related to pulmonary embolus. It's basically the same, a similar pathology with the vasculature, and this is an increase in the pressure, especially in the pulmonary artery, of increase of 5 to 10 milligrams of mercury above normal. 20 to 25 millimeters of mercury is the normal pressure, and a rise above that, and can be significantly more than that, to be honest with you. Usually this is due to a hypoxemia. Hypoxemia is going to cause vasoconstriction of the pulmonary arterioles, and so as a result of that constriction, it increases the work of which side of the heart? The right, yes. Increases the workload on that right heart. The right heart, remember, is not the strongest part of the heart, and it's having to work much harder, and that is it's problematic. So there's three main contributors to pulmonary hypertension: an increase in the pulmonary blood flow. So anything that would increase that flow would certainly predispose or increase the pressure, increases the hydrostatic pressure by increasing that. We turned on the spigot, remember, of the pulmonary artery, and therefore the increased pressure in that vessel. The left atrial pressure, so back up. If the left ventricle is failing, then backing up into the left atrium will cause backup into the pulmonary system as well, and then an increase in resistance to flow. And your book has a really nice job on page 470. There's a whole table of things that can contribute to an increase in the blood flow, pulmonary blood flow, increase in the left atrial pressure, and increase in resistance to flow. You'll find some examples, so I won't go through those. The next slide there is about various classifications. Don't spend a lot of time, but just looking at the various contributing, classified based on cause. Keep in mind that as you increase that pulmonary hypertension, there becomes a thickening of the pulmonary artery. Thickening because of fibrotic tissue. There's a chronic inflammation, and that lays down, that causes a fibroblast to lay down connective tissue, and there's an increase in the muscle tissue. Oftentimes, increase in the muscle tissue in vessels, in veins where there isn't any normally any muscle as well. In addition, you can develop atherosclerotic lesions. Those are normally arterial, but you can develop atherosclerotic lesions secondary to damage in the pulmonary artery as well. Primary hypertension, more rare. This happens more often in females, middle-aged females, and secondary would be secondary to cirrhosis, secondary to HIV. I'm not exactly sure the mechanism there. Those would contribute. Those would be secondary causes of pulmonary hypertension, and certainly left heart failure. Early symptom of pulmonary hypertension would be exercise intolerance, because there's an increase in the demand. It's going to increase the flow. And then certainly dyspnea, and then even syncope or fainting. Over time, there's also a possibility of the development of hoarseness because the recurrent laryngeal nerve gets pressure on it from the distension of the jugular veins from the superior vena cava. The backup into the right side causes increase in the superior vena cava. That puts pressure on the recurrent laryngeal nerve and causes that hoarseness. Okay, and then finally the end result of this is cor pulmonale. Cor pulmonale is right-sided, right ventricular hypertrophy. Right ventricular hypertrophy is happens as a result of right failure. I should say it starts with hypertrophy, and that leads to failure. Why is it hypertrophied? Because it's a muscle and it's working harder. Why is it working harder? Generally because of some sort of a hypoxemia causing constriction of the arterioles, and therefore having to work hard against that resistance, that afterload. It's also important to keep in mind that that cor pulmonale is usually secondary to a pulmonary disease. Right-sided heart failure, cor pulmonale is pulmonary disease. However, the causes of right failure need to include left failure, because as we know, it's a system. So if the left side fails, then the right side is going to fail. So you have to keep that in mind. So keep in mind, pulmonary hypertension is to cor pulmonale what systemic hypertension is to left heart failure. Okay, so systemic hypertension, the left side of the heart has to work harder to push against that. Pulmonary hypertension, increase in the pulmonary artery leads to cor pulmonale, which is right-sided heart failure. It's important to point out that the problem is not only in the heart and heart failure, but backup leads to backup in the portal system. Congestion of the liver, causing atrophy, necrosis of the liver failure, and then ascites or edema in the peritoneal cavity secondary to oncotic changes. And in addition to that, if the liver is not metabolizing, not breaking down aldosterone, remember aldosterone, the sodium hormone, so if the liver is being destroyed, it's not able to break down and metabolize aldosterone, you're going to hold on to sodium, you're going to hold on to water, and that's going to increase the pressure, increase fluid, makes the heart work even harder, and going to increase the rate of edema as well. Kidney failure, secondary to cor pulmonale, you're going to have a decrease in the glomerular filtration rate, and then kidney failure. You're going to have congestion in the upper part of the body in the brain, the gastrointestinal tract, and certainly this jugular vein distension, which actually can be measured. There is a test you can do, especially with somebody with ascites. You want to look and see. You're looking at the jugular vein distension. There's a little measure you can do to see if how much, and we certainly have better diagnostics in that at this time. Okay, enough of that section. To be continued.